My name is Michael Cook, and I'm a cancer epidemiologist at the US National Cancer Institute. My research focuses on Barrett's esophagus, which is the precursor metaplasia of esophageal adenocarcinoma. We know that Barrett's esophagus increases the risk for esophageal adenocarcinoma by 10 to 55 times that of the general population. What we don't know is whether Barrett's esophagus also elevates risk of cancers of other body sites or of other specific causes of death. For example, there is evidence from other countries that Barrett's esophagus may increase the risk of colorectal cancer or cardiovascular disease. To study such questions, I collaborated with Dr. Douglas Corley of Kaiser Permanente, Northern California, to conduct a large cohort study of individuals diagnosed with Barrett's esophagus. Our goal was to estimate risks and provide an evidence base for potential clinical translation. To conduct the first comprehensive study of cancer incidence and mortality risks in a US Barrett's esophagus population, we identified all cases of Barrett's esophagus that were diagnosed in Kaiser Permanente, Northern California between 1995 and 2012. I'll now refer to Kaiser Permanente, Northern California as KPNC. We used the KPNC Cancer Registry and mortality files to estimate standardized incidence ratios and standardized mortality ratios. These are the relative risks of outcomes, in this case cancer or death, to what would be expected in the greater KPNC population. We also estimated excess absolute risks. This is the excess number of events, in this case cancer or death, that would be expected in 10,000 Barrett's esophagus person years beyond what would be expected in 10,000 person years of the greater KPNC population. We adjusted all of these estimates for age, calendar period, and sex. Let's start with the risk of developing esophageal adenocarcinoma. We had 121 such events in this Barrett's esophagus population, providing for a crude incidence rate of 2.5 per 1,000 Barrett's esophagus person years. This translates to a crude annual absolute risk of 0.25% or 1 in 400 person years. This lower crude rate, relative to what has been previously reported, may be due to the fact that the KPNC population provides for a community-based cohort. When adjusted for age, sex, and calendar year, the relative risk or standardized incidence ratio of esophageal adenocarcinoma in this Barrett's esophagus cohort was 24 times higher than the risk in the greater KPNC population. The excess absolute risk was estimated as 24 cancers per 10,000 person years. The risk of dying from esophageal adenocarcinoma was slightly lower, with a standardized mortality ratio of 10 and an excess absolute risk of 15 deaths per 10,000 person years. Taken together, these findings suggest that the real risk of developing esophageal adenocarcinoma over time since diagnosis of Barrett's esophagus is stable, and that the decreasing risk of incident esophageal adenocarcinoma that was observed in the data is attributable to prevalent disease. This was also supported by our sensitivity analysis. For non-neoplastic mortality, risks of death from diseases of the respiratory system, diseases of the circulatory system, and diseases of the digestive system were all increased relative to the greater KPNC population. Yet, when stratified by time since diagnosis of Barrett's esophagus, all of these risks decreased with time, and only death from diseases of the respiratory system remained significantly elevated in the last time period, which was greater than or equal to 6 years. This suggests that elevated risks of diseases of the circulatory system and diseases of the digestive system are the result of a diagnostic bias. For example, cardiac ischemia can cause gastrointestinal bleeding, which may lead to endoscopic evaluation and an incidental diagnosis of Barrett's esophagus. Cardiac ischemia can also lead to subsequent cardiac death. Therefore, it is likely that only death from diseases of the respiratory system is elevated in US Barrett esophagus populations. Our estimates indicate that this is a 51% increased risk, which translates to an excess absolute risk of 12 deaths per 10,000 Barrett esophagus person years. In sum, the excess absolute risks of cancer and mortality in this US Barrett esophagus population are modest, and this includes esophageal cancer, for which the absolute risk appears low and persistent. In sum, the results of this study may inform the potential benefits of surveillance endoscopy, additional screening colonoscopy, and prophylactic interventions in US Barrett esophagus populations.